Hi, good evening, everyone. Today I was thinking of sharing one of the cases I did some time back. Are you all able to see the slideshow
Yeah, you can
Yes,
proceed.
yes,
and able to hear me, right?
Yes.
yes, Arun. Yes.
Yes. So it was a bilateral case of DDH. It was a lady. She came 50 years old, limping since birth. She had severe pain while walking, and when she came to me in OP, she was in wheelchair, and she has remained non-weight bearing for the past 3 months. So this pain has gone to an extent that she couldn't walk anymore, and that was a bit fishy for me because starting with DDH, I have seen most of the cases they don't have any issues walking and all. So I just wanted to rule out any systemic inflammation also. So did a blood workup and everything turned out to be normal. Her X-ray was done, and left side was Crow 2, and right side was around Crow 3 or 4, and severe OA changes and movements clinically were very little, jog of movements only, and the spine was also degenerate with scoliosis. And to obtain a stabler version, CT was done, and the native acetabulum and how dysplastic it was, we just got a idea about it. We also measured the femoral metaphyseal diameter and the femoral shaft diameter. And I decided to go with the right side first and then do it staggered because I thought the acetabulum is a little bit similar to the cup shape on the right side. And for this side, I chose to do the soft tissue releases instead of going for a subtrochanteric osteotomy. I chose SROM implant, and based on this Wu et al. Paper, I did soft tissue releases, got the center down to the original hip center, and then completed this side. And a few weeks later, I decided to rebuild the acetabulum on the left side. So I didn't want to do it in a single stage for the left side because I was not very sure I'll be getting the acetabulum right. So I took the femur head and then made it into a graft, prepared the base, and then fixed it with a screw. So, and then allowed the graft to integrate for 8 weeks. Then later opened it, did a subtrochanteric osteotomy to bring it down. This side I chose to have a higher hip center compared to the right side, a little bit higher, and did a subtrochanteric osteotomy. The patient was kept for non-weight bearing for nearly 6 weeks. After that, this is the healed subtrochanteric osteotomy. All the encerclage wires were prophylactic fixations, so I didn't want those bone to crack away. And this is her current walking 8 years after surgery. So she is not having much issues. She is able to take care of her day-to-day activities. And currently, she had a grievance at her place. She lost her husband. She called me and then she told she's very happy that she's able to manage and take care of all her day-to-day activities and do some work to make a living. Yeah, that's it.
Yeah. Can you go to your post-op X-rays?
Sure. Which one? The original one or the final?
The final one.
This is the first post-op X-ray.
Final, bilateral. Yeah. Any questions, sir? Yeah.
Hi, Dr. Arun, Dr. Venkataraman here. That was a great job, I think you did. Just a question, like, did you do the bone grafting of the opposite acetabulum during the first hip surgery, or was it therefore you did three surgeries?
The patient had 3 surgeries. The first hip surgery was on the right side. The second one was to remove the head and then keep it as a graft. And the third one was to do the proper hip replacement on the left side. Anyway, she was not weight bearing for past 3 months. So I spoke with the patient regarding this, and then they were okay. And the main thing was, when we are using acetabular graft, it has to be non-structural, and we are keeping this cup there. So we need to have at least 60 to 70% of native bone contact for it to have integration. So I can see the graft being kept a little bit eccentric, so that I don't rely too much on the graft for the stability of the cup. So yeah.
Yeah, that's very good. Yeah. Thank you for that.
Thank you, sir.
Thanks. Good job. Is Parishek ready?
Yes, sir. Okay, present now.
Sir, any more questions, anything regarding the case?
It's come down by Arun. How many centimeters has it? You pulled
Actually, it was around, on the right side, it was around 5 to 6 centimeters. On left side, it was a little bit lesser, around 4.5 or 5.
No nerve
So-
symptoms?
For the right side, you said you just did a soft tissue release.
Yes,
But on the left
I was a
side,
little
how-
bit concerned about the sciatic nerve, but while doing the releases, I was constantly palpating the nerve. It was not very much tight. So
But there is a, on the left side, you said you did a osteotomy. So
I
what
found
is the-
osteotomy was a lot easier.
I mean, the left side was, I mean, the soft tissue was much tighter on the left side.
Yes.
Was that related to the first procedure? I would have
Uh,
thought you could have
I don't think so,
released-
sir. I think I chose each technique on each side just for academic interest. I wanted to see how things are happening on both sides. And I just went with described patterns. So I just getting familiar with both of those things. And both side, I don't see any functional changes on both sides, but there is described risk of sciatic nerve palsy that can happen with soft tissue releases, because in subtrochanteric osteotomy, we are not altering the length of the sciatic nerve. Here, we are actually bringing the entire thing down. So probably because we are also releasing the piriformis, maybe sometimes that is preserving the sciatic nerve because the tension is released a little bit. But fortunately for this case, there was no palsy.
It was quite a bit of release, about 5 to 6 centimeters, you said. So
Yes.
lucky that you don't have any stretch
Yes,
on
yes.
sciatic nerve.
Yes. Because I was constantly palpating it in full flexion, and I was ready to switch it to subtrochanteric osteotomy at any time. But I think if we don't take that precaution, or if you are not so lucky, we might still end up getting sciatic nerve palsy.
What is this palpating the sciatic nerve to know whether it's getting paralyzed or not? What is
No,
that?
the tightness, when we do a lengthening of hip, we examine the hip in the flexion and extension. And if we are able to comfortably insinuate 2 or 3 fingers just anterior to the sciatic nerve, it means there is quite an amount of play in it. So it is not like getting very tight. So if you are going to put more traction on it, it becomes like a bowstring. It's more a chance that it's going to get to have a tractional injury. So that's what I do.
Dr. Arun,
Yes.
just a couple of points I wanted to comment. One was the right side was much higher than the left side. Am I correct in that? As
Yes,
a preoperative?
yes.
You chose to do a subtrochanteric on the left side rather than
Yes.
doing knees on the left side. Any particular reason you were thinking like that?
Once I did the cuts, once I took the cuts, somehow on the right side, it was coming down a little bit easier than on the left side. So, and I also chose to do the right side first, thinking that it will be the more difficult side.
And also in your last video of the 8 years follow-up,
Yeah.
Correct me if I'm wrong, but I thought maybe the right side, she had a Was it on the left side? Which side was more Trendelenburg? I can't make out. Or bilaterally, it's the same, is it?
Yeah, it's almost same. And I think she initially have been walking and having the same way. She's also having some kind of a scoliosis and spinal issue. There should definitely be some gluteus medius weakness or whatever atrophy here. But I don't think it's bothering her too much. And the implant is surviving. So I think it was good.
No, I don't mean that. I mean, luckily, I mean, you've done a good job. I'm not saying that. What I'm saying is that objectively, did you feel that the right abductor was weaker than the left abductor?
Objectively, I didn't see any difference. It was almost like symmetrical. Even when she was walking, you can see the swaying is almost equal.
Yeah.
So I didn't see any difference because in we are not releasing the abductors anyway. So in that Wu et al. Test, the sequence of releases starts with the adductors, and then we go around posteriorly, and then come to gluteus maximus. And finally, most of the time, when we do a lengthening of the hamstrings, it just comes and sits in place.
Just for academic sake, I'm not criticizing anything. Just for example, these cases, it is not Crow-4 dysplasia. It is 2 or 3. In dysplastic hips, we follow Wolff's law. So wherever the bone gets loaded, there is a good bone stock. So there only you should keep the cup. So for Crow 1 and 4, you can keep it in the native acetabulum. For the Crow 2 and 3, you can keep a little bit high hip center. Usually STS4 is needed only in cases of Crow 4, like that. And you need to take a full length X-ray of the femur also, because in case of Crow 4, there can be a femoral lengthening also. Compensatory femoral lengthening. So in that cases, mainly to get it down in a Crow 4, we do an STSO. Rest of the cases, I think little bit high hip center and then low offset stem, we can manage, I think. Good.
Yes, correct. Thank you. I think in this case, I have chosen a little bit higher hip center. You can see on the Crow 2 side. Here it is almost as close to the operator foramen. Here it is a little bit higher. So here I chose a higher hip center. I think we are agreeing on that.
No, you
would
should
say-
have tried a larger cup on the left side, no? That would have been easier because of avoiding the graft.
Yeah, probably, but the shape was not
Because that
very spherical.
it's because of it's bigger, and that's no migration at all. So that you would have get along with the larger cup itself instead of that graft getting incorporated and a lot of worries.
Maybe,
would have
but
tried that.
here the shape was a little bit not correct, and
Yeah.
the
You
acetabulum
can
was a
use
little
the
bit
head as an
softer.
impaction graft, and then you should have put a larger cup as well.
Maybe, but the bone was a little bit softer because she has not had a bearing weight in that. And
Okay.
even putting this cup, it was almost touching the inner membrane. So I don't know whether putting a hemispherical cup that big, I would be having enough bone stock on the medial side.
Sir, if you go for a bigger cup, it eats the AP diameter, sir. That's the issue. If you go with a high hip center and it'd be okay, I think, sir, with a smaller cup.
No, if you're using a bigger cup, you
my
can
doubt
use
is
the
what this.
weight bearing.
My doubt is, should you have to choose even a higher hip center than this, or would this be okay in future
Left
cases?
side also higher hip center would have been better because you should avoid the medializing the cup instead of anterosuperior. That the bigger cup would have been easier to get along with that.
Okay.
Because that bone stock anterosuperior is very strong actually, and very.
And the STSO is the correct side, sir. Left side, it is little bit at a lower level, no? STSO.
The whole pelvis is a bit tilted.
Okay. In your distal fitting,
So-
it doesn't matter.
Functionally, the patient
How
is
was
doing well at this stage.
Arun, how was the graft when you went in? After 6 weeks, is it 6 weeks?
Yes.
8 weeks.
8 weeks.
I see you removed that screw which was holding it there.
Yes.
So it was consolidated, is it? It was joined up with the.
Barely consolidated. I just wanted to make sure I am not relying on that graft for the cup hold. So I just removed the screw and then did the reaming and saw how the fit was. Because if
So
I am relying on the graft, it is going to just pop out.
Arun, having gone through this once, how would you do it the second time if if a case comes to you like this again? Would you again
I think
adopt the
I'll
same?
choose the subtracant reconstructing. I feel it's.
What about the graft? Would you do the graft or just leave?
I might not do the graft. I was a bit more cautious that time. I may choose to keep the cup and then fill in the void with the graft in the same speed.
Okay.
Dr. Arun, very nicely done case. I just have a question for you. When compared to the left side, that sleeve position is different. Do you felt any difficulty in inserting the sleeve when you do it on the right side, or any difference when you apply it for the opposite side?
No, sleeve position. I don't think it matters as long as we get a good hold over there. So even if it is going to be outside the bone and is just standing outside, I think if you are getting a good grip distally, I think it should be fine.
Okay. Sir, can we move on to the next case, sir? It's 9:35. Thanks, Dr. Arun, for the presentation. And it's actually has done in the early part of his career, these cases. It's with 8 years follow-up, which we must definitely appreciate him. Thanks for the nice case presentation.